So I'm going to present the experience from Cedars-Sinai on behalf of Raj Makar and the team there. Despite all the advances we've seen in transcatheter valves, all the advances we've seen in the techniques we use to deploy them, the risk of stroke remains a concern. In contemporary trials, as Dan showed, the risk of stroke persists at about 5%. Stroke, I think, for physicians and patients alike, is our most feared complication. And anyone who's had a post-TAVI stroke has increased mortality, increased length of stay, and the cost of hospital admission is much higher. The Sentinel Cerebral Protection device is a device with two filters. The proximal filter sits in the brachiocephalic trunk. The distal filter is positioned in the left common carotid artery. And as the image on the right shows, that covers 90% of the cerebral circulation. Here's a short demonstration of the device being deployed. A coronary guide wire with the device on it is advanced into the ascending aorta. The proximal filter is deployed. The device is flexed, and the tip of the device is directed towards the left common carotid. The coronary guide wire is advanced into the left common carotid, followed by the filter. So this is the filter going into the left common carotid. And that's where the device sits. And although it's not necessary, you can do an angiogram to prove an adequate position of the device. From a practical perspective, at that point, what we do is we stick the device to the table, and then we cover it up with a drape. And that means you can then carry on with the TAVR, nothing gets in the way, the device is safe and protected, and you're not going to pull it. As another point, which hasn't yet come up, the device doesn't interact either with the valve, or if you're doing coronary protection and you have enough access, you can do Sentinel and coronary protection at the same time without any issue. This is some debris we have seen at Cedars-Sinai. In pretty much every case, there is visible debris in the filters. In June of 2017, the FDA cleared the Sentinel device for use during TAVR, and at that point, we decided that cerebral protection should be the standard of care at Cedars-Sinai. We have a core lab that analyzes all our CTs, and we just added an extra image to their data set, which is an image of the aortic arch in a suitable view. Generally, it's LAO 20 to 30, and that allows us to plan the procedure and determine whether cerebral protection with this device is possible. So since FDA approval, we have done, in that year, we did 618 TAVIs. We attempted Sentinel cerebral protection in 484 patients, and it was used in 456. The stroke rate at 7 days was the endpoint we were looking at. This is a breakdown of the valve type by the two groups, the Sentinel arm and the no Sentinel arm, and this is just to illustrate the point that the valve type isn't a consideration for us when using Sentinel. We use it for whatever valve we're using. So just to spend a minute or two on the reasons for not deploying a Sentinel device. Obviously, if you can't advance the device, despite the tricks we talked about, getting the patient to take a deep breath and bad radial spasm, although I have to say radial spasm is very unusual with this device, actually much less so than with radial PCI, in my experience anyway. The reasons we didn't attempt CPD at all was either because the patient was screened out due to unfavorable anatomy. I think what we would view as unfavorable in June last year is not the same as what we view as unfavorable this year, and we're much more willing to try the device now. We used to feel that aortic regurgitation, if there's no calcium on the valve, they don't need cerebral protection. I think, as Nicholas's circulation paper shows, it's not just the valve, it's the aortic arch, it's thrombus from the myocardium, bits of myocardium, all of those things are relevant, and therefore we would use the Sentinel cerebral protection device even when it's pure AI, even if there isn't substantial valvular calcium. Here are some of the considerations that we have when we're planning a procedure using cerebral protection. Most of the TAVI population has a lot of vascular calcium. Vascular calcium in itself is not an issue. What matters is vascular calcium causing stenosis.
I don't use.
Severe tortuosity, for the most part, you can get past it with the device. It's very flexible and easy to deliver, we generally wouldn't exclude a patient on the basis of tortuosity from the CT, because you never quite know until you get there, and in most patients you can deliver the device. It's quite uncommon to have a stenosis at the origin of the left common carotid or at the origin of the brachiocephalic trunk, but if you do and the vessel size is too small, the number we use is 6 millimeters, then we would not use cerebral protection. Since using this device, I've learned a lot more about aortic arch anatomy. There's quite a lot of variability between different individuals. Most patients have a type 1 arch, that is the left common carotid is a branch of the aortic arch itself. 10 or 15% have a bovine aortic arch, a type 2 arch, that is where the left common carotid is a branch of the brachiocephalic trunk. Now, in the early days, we would exclude these patients from using the Sentinel device because it's quite difficult if you're trying to steer the wire into the left common carotid with the device itself. It's quite difficult to get the right angle. What we do now is we have a slightly different technique, so we use a long wire, same kind of wire, so a balanced heavyweight or a choice PT. We use an exchange length wire on a JR4 4 French catheter. We advance the 4 French catheter into the ascending aorta, withdraw the wire, pull the catheter back until it engages with the ostium of the left common carotid, then advance the coronary wire into the left common carotid, remove the JR4 catheter, and then you could advance the Sentinel device over that wire. So most bovine anatomy, you can now deliver the Sentinel device, and that's what we do. To give you an idea of our learning curve, in the last 200 patients we've used this device on, we used it in we attempted it at 178 patients, and we had successful deployment in 166, so that's a 93% device success rate. To give you some of the details of the procedure, echoing what's been previously shown, there is no significant difference in the fluoroscopy time, the radiation dose, or the contrast volume. The graph on the left shows the absolute difference in stroke rate in the Sentinel patients versus the no Sentinel patients. 5 patients, that's 1.1% of patients who received the Sentinel device developed a stroke. That's compared with 8 patients, or 4.9%, in the group who did not. That equates to a 3.8% absolute risk reduction and a 78% relative risk reduction, giving us a number needed to treat to prevent 1 stroke of 26. To put that into context with the rest of the data, the Sentinel trial, the Ulm study, the Erasmus data, and ours, the relative risk reduction is similar in all of those 4 different cohorts of patients. So I'm coming at this from a slightly different perspective. I've trained in the UK National Health Service, and now I work in a big academic medical center in the US. And while access to medical devices there is easier than it is here, the cost of an individual procedure, particularly the fixed cost, is under a great deal of scrutiny. But those discussions generally fail to take into account the cost of a stroke. In our experience, the number needed to treat to prevent 1 stroke at 7 days is 26. The cost of the Sentinel device in our institution is $2,800, and the cost of preventing a stroke is therefore $72,800. Stroke, I think we all agree, is a devastating complication. The stroke rate, everything else in TAVI is getting better. The stroke rate persists at 4 or 5%. The enormous physical, emotional, and financial cost of stroke has already been discussed. And I think we also need to think that as the indications for TAVI expand, as we start to do TAVI on younger patients, where there's obviously an increased prevalence of bicuspid valves, the stakes are even higher than they are now. The Cedars-Sinai experience is that the Sentinel cerebral protection device is quick, it's easy, and it's safe. It's now part of our routine TAVI practice. We've noticed no significant difference in procedure time, X-ray exposure, or contrast use, and stroke rates were significantly reduced with the use of this device. Thank you very much.